So welcome to my stakeholder session on our system redesign that is influencing community connections. My goal today was really take what has become a very complicated situation and make it relatively digestible so that people can understand what's going on, hopefully without being overwhelmed by the information. So hopefully I strike a decent balance, but if anytime you need me to back up, fill in, just let me know. I think the other thing that I really want to strike a good balance is that this is a lot of information, and I think it can bring up some emotional reactions in people. So I'm also trying to strike that balance of, I want you to be informed. I want people to know what's going on in our community and in our company, but I also don't want anyone to panic, right? Our big goal out of all of this is I will fight to the death to ensure that people in our communities who have disabilities have the services that they need. That is, my ultimate goal throughout all this. And so I really don't want anyone to think, oh my goodness, we're not going to have, we're going to have gaps in services. We're going to have problems. So just want to make sure you understand, yes, I'm sharing this information. It's big shifts, and there's a lot of people working on this to ensure that people with disabilities continue to be served in Southwest Colorado. So thank you so much for being here to go through all this. I am Tara Keene. I'm the president and CEO at Community Connections, and also want to kind of give you the disclaimer. This is a huge statewide systems change, but I am very much looking at this through the lens of community connections, right? How is this impacting our organization? How is it impacting our communities? So at the end, I have a link. The Department of Healthcare Policy and Financing has a great website that has the kind of high level, here's what the system redesign changes are looking like. And that's going to have a lot more general information about this system redesign. But I'm really focusing on, and what does that do for community connections? So I am going to go ahead and share my screen, share a little PowerPoint so that I stay focused and on topic, because otherwise I can go off into many tangents, I'm sure. So hopefully you are seeing a slideshow on your screen now. All right, so again, this is really about the future for our services for people with intellectual and developmental disabilities here in Southwest Colorado, and what things are looking like for the future. So to start with, I want to ground us all in what exactly Community Connections is and does. A lot of people are probably familiar with one piece of our services, but maybe don't know how we fit into the bigger system. So let's look a little bit at the entire Colorado system for people with intellectual and developmental disabilities. So when we look at the structure of our overall system, of course, we have the legislature that writes laws, but then we have the executive branch enacting the laws, and they have all of these departments who essentially help put what's in our laws into rule and then into practice. So most of our services fall under the Department of Healthcare Policy and Financing, and specifically within the Office of Community Living. And the Office of Community Living is the department, or the piece of the department that handles Medicaid services for people who are getting services within the community. So places like our home and community-based waiver services, assisted living, nursing homes. So any place where people are getting more than acute care, right? That they are getting long-term services within our communities. So one piece of that, of course, is services for people with intellectual and developmental disabilities. And to do that piece of the service system, back in the 60s and 70s, as people were moving out of institutions or wanting to move out of institutions and into communities, it was generally parents who were designing service systems for people to have support in the community. And in Colorado, these became known as community-centered boards that were kind of the one-stop shopping, or the all things intellectual and developmental disabilities. And so each region of Colorado was assigned a community-centered board who would do all of the information and referral, intake, eligibility determination, service planning, and then a lot of the actual direct services for the programs that were available. And of course, over the years, more and more people wanted these community-based services, and there was, much more demand over the years. And so a lot more organizations and agencies were needed to meet that demand. So over the years, different organizations, businesses also started providing some of those direct services for people with developmental disabilities. Originally, those what we call PASAs, or Program Approved Service Agencies, were directly contracted by the community-centered boards. So the community-centered boards were kind of responsible for the capacity in their regions and would contract directly with those Program Approved Service Agencies. About a decade or so ago, that really started shifting to the Program Approved Service Agencies contracting directly with the Office of Community Living. And that was kind of the beginning of some of the shift in the role of the community-centered board within the communities. So let's look at some of those roles. So the community center boards, we are now designated by state statute. We are defined what we do and in what region is designated in our actual state statute, our laws. And we are the community centered board that covers this 5-county region in Southwest Colorado of Archuleta, Dolores, La Plata, Montezuma, and San Juan counties. We are actually one of 20 in Colorado. So each region has their own community center board. They're all separate private nonprofits. It's not like we're part of a larger organization, but we're all doing very similar things within our regions. And so at Community Connections, we're essentially serving in 4 roles. So we are that community center board that is designated in state statute. And so we are doing that kind of, overall making sure that services for people with intellectual and developmental disabilities happen. There's a lot of administrative functions that are a part of that. But also a big piece of that is the second role, which is CCB case management. So that intake, eligibility, service planning, service monitoring is all a part of our CCB role for the programs that are designated for people with intellectual and developmental disabilities. Then fairly recently, just in 2020, we added another role as the single entry point case management agency in 3 of our counties, in Archuleta, La Plata, and San Juan counties. And this is very similar case management like we do for the community-centered board, but for very different populations, or somewhat different populations. So people with brain injuries, people with behavioral health diagnoses, older adults who are experiencing disabilities as they age. So while it's the same sort of work, it also expanded the scope of who we're serving in some ways. And then our 4th role is as a program approved service agency, that we do a lot of that direct service. We're in a rural area where there's not an awful lot of options, and we are still the provider of a substantial amount of those direct services. So as a case management agency, we provide case management services for these variety of home and community-based waiver programs. And on the left, you'll see the ones that fall under the community center board, on the right, the single entry point. But for all of these, we are providing case management services. So then when you look at our direct services, you will see some overlap, but obviously, if we go back to the last slide, there are far more programs that we are providing case management for than we provide direct services. So our direct services, we have children's extensive support, day habilitation and supported employment, which are actually services within the supported living services and residential waiver programs. Any questions about the actual programs that we're talking about before I move on? All right, we'll have lots of time for questions at the end as well. So this all seems reasonable, stable. So why am I having this webinar or meeting about changes to our system? Why do we have to change? Well, to answer that, I want to back up and first talk about conflict of interest. I'm presuming that most people are somewhat aware of what conflict of interest means. It's basically when we have we're in a situation where we may have competing loyalties. I picked a silly little cartoon to just give one example. Physician prescribing you a medication. Maybe it's not the best medication for you, but it's going to make some money for him. And I think it's a great example of how conflict of interest can run a spectrum from, absolutely illegal to unethical to a little bit sketchy to it's just something that's part and parcel of someone's life, and we find ways to mitigate it. I think more on that end, we see examples like teachers who are teaching in a school where their child is a student. They may encounter situations where what's good for the school isn't what's good for their specific child, and they may feel torn, between their loyalty as an employee and their loyalty to making sure that their child has an excellent education. And yet we see teachers teaching in their children's school all the time. We don't see this as unethical or a negative conflict of interest. It's something that we find ways to mitigate. A lot of times it's about transparency and just naming this conflict of interest exists and finding ways to work around it, build firewalls, mitigate it in some way. Well, Community Connections has a conflict of interest, and you may have already been putting that together by some of my descriptions of what we are doing. We are essentially writing plans for people that could have an impact on our business. So with our case management, we are helping people design their services, designing their plans, and then in many cases, we are providing those services as well. So there's the potential, kind of like that doctor writing the prescription, for us to guide people, steer them to services that are financially appealing to us, and guide them away from ones where maybe we have staffing issues or have financial losses. And this has been really baked into our Colorado system from the very beginning. So this is not at all illegal. There's some difference of opinion of whether it's unethical, but it has been our Colorado system since the beginning. And almost since the very beginning, there has been a discussion about the conflict of interest that's inherent in our system. Over the years, as a state, we've looked at it and said, yep, there's this conflict of interest, and we also see other benefits from this system, cost efficiencies, kind of that more seamless system when people aren't having to go a whole bunch of different places to get what they need. And so for many, many years, we looked at it as the benefits outweighing the risks. Really tried to put in those firewalls to mitigate, to be transparent. But throughout, there were many, many people who said, this isn't enough, where there really is this conflict of interest and it really is hurting people. Well, finally, the feds came in and said, okay, all of you states who are still doing this, case management and direct services within the same organization, that's fine, but you're not going to get our money anymore. We're changing the rules, and if you are getting federal money, you're going to have to separate case management from direct services. And of course, this came out in 2014. At the time, Colorado had about a 1-to-1 match of federal to state dollars. So for them to say, nope, we like our system, we're going to keep doing what we want to, they basically would have been cutting in half our resources for home and community-based services. So obviously that really wasn't on the table. So we had to say, okay, feds, we'll start figuring out how to completely rework our system. The quote here below is the actual piece of the rule that came out in 2014 that says, if you're doing home and community-based services, you cannot be a provider and also doing case management or developing the person-centered service plan. And I want to put a pin in this bolded section that says the only willing and qualified entity, and we'll get back to how that has some impact in just a little bit. All right, so what does that mean? We're huge system overhaul. What does that actually look like? This graphic, I'm just going to show you, and we'll do a little talking around it, but I don't want you to get too focused on this graphic because I think it can be overwhelming, especially for people who aren't part of our system and understand all of these acronyms. But this is basically the vision that the Department of Healthcare Policy and Financing has around what this end design is going to be. So their vision is having this new intake, eligibility, and case management agency for each region. And all of the things listed within this little house graphic are the things that would be part of the responsibilities of that new case management agency. And in this house, we can see a lot of the things that we already do as a community-centered board and CCB case management agency. So all of the service planning, intake, eligibility, all of the care coordination, waiting list management, all of our kind of administrative pieces, our state-funded programs, all would fall within this house of this new case management agency. So I kind of split it up a little differently. This is basically the same information, but if you look at community connections, kind of what would go into each bucket or what would be within the house and outside of the house. So within that case management are the current things that we are doing under CCB case management, our single entry point case management, all of our state funded programs, which includes family support, and then our state and OBRA, which is in nursing homes, supported living services, and then all of the administrative functions that we do. And then here's just a few examples. What's not inside the house, so what would not be part of that case management agency, are all of our direct services. So that includes our residential services like host homes, supported employment, day program. So if you're familiar with our Holly House and Pine Street, those are our day programs. Those are all kind of outside the house. And then our supported living services. So things like personal care, homemaker, and children's extensive support. So an interesting piece, I have this little asterisk saying the CCB designation will be able to live within either of these. And I think that can be kind of confusing to people. So our CCB designation is actually going to be completely separate from either one of these options. You'll see that most of what we currently do within our CCB designation looks like it's going into this case management agency, which is very true. So basically what is going to happen is a lot is going to be stripped away from that CCB designation. So a lot of the things that already come with that are really moving into that case management agency. A couple of reasons that the CCB designation itself is going to stay around. One is that that's where early intervention lies. I haven't really talked much about early intervention because it's not part of that home and community-based services, and it's not under healthcare policy and financing. So they really don't have any authority over what happens with early intervention. Well, currently early intervention, the service broker role is tied to our CCB designation. So whether we decide, to be case management agency or program approved service agency, the CCB designation can live either place. So the other reason that the CCB designation itself is staying around is that there are several communities across the state that have mill levies. And so they actually have local tax dollars that are going to the community center board, and it's tied to that statutory designation. So actually when the voters voted in the mill levy, that statutory language was a part of what they voted on. And so keeping that CCB designation around means we are keeping those local dollars in the system. Whether we don't have any communities that actually have a mill levy, but it's still, it benefits people with IDD in our state. And so they really wanted to maintain that access to resources. So of course we have to think about what's our timeline. This is a major redesign. When do we have to do this? So I'm going to give you spoiler alert, which is down at the bottom. July 1st, 2024, we have to flip the switch. Our original deadline, when, that's like 10 years after that rule came out, right? So the original deadline was supposed to be when Colorado submitted for waiver renewals in 2019. We weren't ready yet. We had a deadline of 2022 originally, so we could be neck deep in this already, except right around the time the pandemic started, new leadership at the Department of Healthcare Policy and Financing really dug into Colorado's plan for the redesign and said, this is really messy. This is not very customer friendly. It's confusing. It's clunky. Maybe it made sense when we first proposed this, but we're not sure this is the best way to move forward. And they contacted the folks at the Center for Medicare and Medicaid Services, who are our federal agency that holds the purse strings and wrote that rule. And the feds basically said, yeah, we thought the same thing when we got your plan. So we're really kind of glad you're re-looking at this. So yes, we will give you a little bit of an extension. But knowing that pretty much we've had 2 extensions already, 2024 is our deadline. We're not going to be able to kick that can down the road anymore. So obviously, if we have to do a pretty major change, July 1st, 2024, we can't start planning that in June of 2024, right? This is something that it's going to be a major transition with lots of milestones and benchmarks along the way. And the first one that really makes a huge difference is that it's currently in legislation that the request for proposals for the new case management agencies will come out in December of this year. So that is the point where anyone who thinks, I think I might want to do that case management piece, they're going to have made a decision by then to submit for that request for proposals. Then, 2 months to really work on the request for proposals, which will be due around February of next year. And then by essentially this time next year, the contracts will be awarded. We will know exactly who is providing case management for each region of our state. So then we have essentially a year to put that into practice, to actually create those case management agencies, do whatever splitting that needs to happen for people to come out of conflict. Well, here's where I want to bring back that idea of the only willing and qualified provider and rural exception. So when the feds wrote the rule, they understood that there are some areas of the country where, sorry, I'm just checking my time to make sure I'm not totally running over on y'all, and we're doing great. So they understood that there are some areas of our country where there just isn't the population or the geographic access to make it reasonable to have multiple organizations providing services. So an excellent example, one of the earliest states to get rural exceptions was Alaska. I mean, there are some very remote areas in Alaska. There are a lot of indigenous populations that have pretty strong relationships with a provider and really don't, they don't want someone else coming in. And so they have been awarded rural exceptions saying, we understand there's not multiple providers. And so that is somewhat of an option. There are a lot of rural and frontier areas in Colorado. Our entire, every county that we serve is either a rural or frontier county. We do have problems finding enough providers. So I do think that there is the potential, if we don't have everything in place, if we haven't figured out someone to fill in all of the services, I think there may be some flexibility in the timing. If we're like, oh, we can't stop providing this service until next December because we don't have someone else set up, I think that rural exception might buy us some time and flexibility. I don't think it's something that we can hang our hat on for a long-term solution. One of the reasons is that conflict of interest does still exist. And so, if we go with the spirit of the law being giving people that really clean case management where they know that their case manager is helping create a plan that is for the person without any other divided loyalties, either intentional or unintentional. I just think it's the right thing to do to make sure that this change actually happens. And I don't think we can expect that there will never be multiple providers available. I just see a lot of expansion and more competition and choice within our system. So it's not something, even though today we may say, oh, there's nobody else to do these services, I don't anticipate that that is the case forever and in the long term. So if you hear us talking about rural exception or only willing and qualified provider, it might be a piece of the puzzle. It's not a solution to the problem. So amongst all this, big changes, and we need to ground ourselves somehow. And I think grounding ourselves both in our mission, of course, but I think even more, my North Star, kind of my guiding star, is our strategic goal of really ensuring that our communities are places where there is true social integration for children and adults with disabilities. So while we have, lots of considerations that are financial and operational and, loyalty to our clients and to our employees and to our communities, I really think that this is our guiding star, that we should ensure that any choice that we make is really furthering this idea that children and adults with disabilities deserve to be fully belonging and fully integrated into their communities. So with all of our talk about the details of the change, I think that is one of the most important things that I know I am keeping in mind and holding in heart, is what is really going to be best for that end goal. So with that, what are our options? What can we do? And I've put this out to several groups of our kind of 4, and these are very high level. There's lots of nuances and details and kind of many options within each of these, but kind of our high level options. These are the 4 that I have identified. I keep asking, okay, what's behind door number 5? You know, are there other options that I am just missing? So far, nobody's come up with any, but that doesn't mean that it isn't out there. So we're very open to, have you ever considered that this might be something we can do? But what we're looking at right now as our 4 options would be: 1, we can submit a proposal to be that case management agency, do all the stuff that's in that house, and stop providing services. So that would obviously mean finding other providers who could come in and provide those services, you know, that we wouldn't just throw up our hands and say, y'all figure it out. But we would, as an organization ourselves, focus on that case management piece. Option number 2, we could just focus on the direct services. We could say that's where we feel like we have the most impact. That's our bread and butter. Let someone else take on that case management piece. Under that option, obviously, that's a contract with the state. And so when I say let someone else take on case management, we would not have a lot of control over that. It would be, you know, whoever decides to put in the bid and whoever the department chooses. The other option, number 3, would be we could split our agency in half. So we could essentially say, you know, we feel like we have a lot of history, a lot of competency in all of these areas, and you know, we would like to continue offering both of these services, but as 2 completely separate organizations. So essentially, you know, one piece would stay community connections, and another organization would grow out of our current team and assets. So we would essentially just kind of unzip 2 very separate arms of our agency, but they would become legally and operationally their own standalone organizations. And number 4, we could take our marbles and go home, right? We could say, this is too complicated, this is too chaotic, this is a mess, we don't like the direction it's going, y'all figure it out on your own, and basically stop doing everything and go out of business. Obviously, this is not our favorite option. I haven't heard anyone advocating for this quite yet, but as long as we have everything out on the table, what are really our options? That is an option. It's not a great option, but it is an option. And who knows, it could happen whether we like it or not. Hopefully not. All right, so that's the end of my slideshow. So I'll turn off the share in just a second so I can field any questions. This link, though, is the one I talked about earlier. That is the healthcare policy and financing webpage for the case management redesign. They're constantly putting updates and FAQs, and I think they have a place where you can actually sign up to get memos and notifications of meetings and such. So that might be a place to go if you have interest in staying up to date with the kind of Colorado system changes. I will also drop that into chat so you have easy access to the link. But then we will also, as things progress, you know, this is just kind of the first dipping your toes in, getting people informed as to what's going on. As we progress, as we have more information, as we have more sense of our direction, we will continue providing information to our communities and giving opportunity for feedback and responses. So with that, I will just open it up. If anybody has questions, concerns, ideas,